Kavita, Ted mentioned OCM 1.0 and OCM 2.0. I think I've even read something about a 3.0. Where are we? How many versions, and how are they different? And to what extent do they try to address some of the things that have come up in the conversation?
So the current model that's in the Medicare program is, the Oncology Care Model is kind of what I guess everyone affectionately refers to as the OCM 1.0. The 2.0 more specifically is something that Ted and myself, and there's a team that have been working from leaders from COA, leaders from community practices, as well as just kind of payment experts in the country, Mark Fendrick from the University of Michigan and some others, to try to identify, like, what is this next, to all the things you're pointing out, Bruce, like, what does it really mean to take risk if you're not taking risk? And so all of these elements are kind of what we're affectionately also calling 2.0. And where is it? I'm personally not aware of a 3.0, but I wouldn't be shocked by that. Or actually maybe there are a lot of people thinking about the next phases of cancer models, and you can kind of put those in sequence. And all of them are struggling to kind of identify what's worked in the OCM. That's something that we're trying to do, what's worked, but then what needs to be improved upon. And I think kind of this conversation around immunotherapy, novel therapies, how do we actually change the way we treat the drugs? And Ted said it better, that this is really about kind of reliable price prediction, or people talk about cost, prices, and charges, kind of conflating the three, but really how can we talk about, like, what is the financial benchmark in an era when survival, every single cancer meeting, even like the small regional meetings, are now breakthrough meetings because some literature about the way we give care in cancer is being changed dramatically. And so the idea that a government kind of set of bureaucrats can make quarterly adjustments to a spreadsheet about what is, quote, novel is actually, hysterical. So that's where 2.0, 3.0, I think everyone's trying to think about what's not working and how do we improve upon it.
Concur?
Yeah, absolutely. I think, we have literally one sheet of paper where we have all the aspects of the 1.0 model and what's right and what's wrong. And the other side of the paper is the 2.0 model. And as Kavita said it, we've got a big team that's been sitting down. We meet regularly. We talk about all the time and saying, what's wrong? What's wrong with price prediction? What's wrong with risk adjustment? What's wrong with things like attribution? And we look at that and say, how should that be different? The other thing is the idea that this, what do we do with this artificial, as Rich said, this sort of artificial 6-month episode? And, we all know that originally, the original plan was, let's take all the services, put it into this 6-month bucket, and then ultimately we'll drop the drugs into it, and basically it'll all be bundled. In fact, that's where they would still like to go, but in terms of CMS, CMMI. But we're looking at it and saying, how do we do differently? And as Kavita said, how do we look differently, especially at the drug piece? I always say this all the time. I said, we are committed as community oncology to basically getting paid for services based on value. Guess what? The same should be on the drug side. So I know that we've had over 80 meetings literally with drug companies looking at the idea of value-based arrangements, whether you're talking about indication-based pricing, outcomes pricing. The interesting thing is a lot of companies now are doing this on the commercial side. They'd like to do it on the Medicare side, but there are impediments. Medicaid best price, ASP. So what's interesting is the government's recognized this and actually have a rule out that would pull some of those off. Senators Cassidy and Warner are basically have a draft bill out that we commented on, that they want to basically exempt literally some of these programs from Medicaid best price and the AKS, the anti-kickback statutes, Stark Law, ASP, and things like that. So think about it this way. Remember that nice little box that Macintosh came out with? Basically, Apple. That was that box. That was 1.0. Look at now where it is, not only in terms of your computer, but your iPad and everything like that. And so we must be on now 50.0. It's the same thing holds true here. You're not going to say this is the perfect model and implement it and say this is it. So we are looking at 2.0. In fact, as Kavita knows, because we've talked about this, we've talked about what should be in 2.0, what will probably be pushed to 3.0 and 4.0 and 5.0. So, but we need to move forward by saying that This was a good attempt. It's basically the model itself is sound, the concept behind it, but there's a lot of the implementation that's lacking that doesn't account for example, the IO drugs coming into the market.